We're glad to see everybody here today. Um, the topic for tonight is going to be on homelessness and street medicine, presented by Dr. Jim Weathers. I'm going to be introducing Eddie Solar here, who's going to be giving a little bit more information about some of his efforts here at Florida Hospital. A lot of the senior leadership here have taken on the task of trying to help combat homelessness here in Central Florida. And it's a dear topic to a lot of Florida hospital people here, as well as a Central Florida issue overall as well. So with that, I'd like to introduce Eddie Solar. He's the Executive Vice President and Chief Financial Officer here at Florida Hospital, specifically at the Adventist Health System for the Florida Division, where he oversees complex hospital systems financial responsibilities. He's very active in the community. Some of his involvement includes sitting on the boards of the Central Florida Commission on Homelessness, the Rethink Homelessness Coalition, as well as the Leadership Network at Rollins College. So please let me introduce Eddie Solar here.
So for those of you who don't know me well, I've spent basically my almost entire adult lifehood working here at Florida Hospital in the finance area. As Steve mentioned, I've recently moved to our parent organization, Adventist Health Systems, and so unfortunately, Steve, I can't call myself part of Florida Hospital anymore, which is really tough sometimes. And those who know me also know I have a real passion for caring for those less fortunate, and in particular the homeless. And I've been on a journey, if you will, for the last 5 or 6 years, starting with just ignoring that they even existed. And it took a 60 Minutes episode that I think many of you probably saw, I don't know, 6 years ago on homelessness in Seminole County. And I was shocked and disappointed, shocked that it was happening and I didn't know, and disappointed that it was in my own backyard. And then from there, I had a family member who had a behavioral health episode, very acute. And it became clear to me that there was no safety net in Central Florida. And if my wife and I hadn't stepped in, she would be one of the other homeless individuals out on the streets that people would look at and say, why don't they get their act together? And the truth is, she can't. From there, I joined the Central Florida Commission on Homelessness and met Andre Bailey, and he educated me quite a bit on the chronic homeless and this concept of permanent supportive housing. And as the finance guy here at Florida Hospital, the concept made a lot of sense to me. And one, I think our mission called for us to get involved and have these folks be treated and live in a more compassionate manner. But I'm also of a belief that, financially there is a better model. Simply ignoring the homeless doesn't cost society any less. And Central Florida has come a long way. Last I heard, the annual count that was done, I think we've dropped the chronically homeless by almost a third. And that's great progress. Now, we've got more work to do, but that's great progress. I was talking with Dr. Withers a little bit before the presentation, and I had to tell him, the program and the work that he's done is really unique. He's sort of the Marcus Welby for the homeless. Most physicians don't make house calls today, period. And his model is you're actually making house calls with the homeless. You're out there in the woods or under the bridges. And I have to admit, I hadn't really even thought about that. So I am really looking forward to hear some of the stories of what he's done. And who knows, maybe it's a concept that kind of gets ignited here, and we figure out if maybe there isn't a need for that in our own home as well. So please join me in welcoming Dr. James Withers.
Thank you so much for coming and inviting me and just being interested in your brothers and sisters who aren't doing as well out there. So the practice that I do, I now call street medicine. It's just a term I needed to describe an activity that I got involved with back in the early 90s in my hometown here. I made house calls with my dad as a kid. We went into rural Pennsylvania, and I learned to parallel park with my mom, who's a nurse, doing Meals on Wheels. So I just had a really good childhood where connecting with people in their own world and on their own terms was just natural. Worked overseas with my folks when I was a teenager, and in my own work in India a little bit as well. But I decided to really invest myself in my Pittsburgh community after finishing medical school there. And one of the first, arenas that I got involved with, well, I can see my slides don't quite fit this, but I decided that I needed to recapture that house call concept. And I wanted it to be in my town. It had to be with people that were excluded, for whom it wasn't working, for my big hospital system, Mercy, there. And I particularly wanted people who were kind of stubborn and wouldn't necessarily do what I told them. Because as a medical educator, I wanted to be able to stretch myself and my students into being limber and nimble enough to meet people on their own terms. And so I thought, the folks that are under bridges might be the very teachers that I needed. Just to backtrack a little bit, and I don't mean to shock you guys with this next picture, but this domestic violence was the arena that first really caught my heart as a teaching doctor. And I'm very grateful to this woman and to others who trusted me enough to let me know about their issues. This was something she gave from her purse. A friend took this picture because she had been seen in our ER. She didn't think there'd be any help for her, but her friend took the picture in case later maybe she'd be able to go to the courts and get some justice for her situation. So domestic violence was something I sunk my teeth into because the more I asked about it, the more I realized it was everywhere. And it was affecting people who were basically invisible to us. If you will, their reality was invisible to us. They were ever present. And as a system, we kind of didn't even see it, or if we did, we were looking at a headache. We were looking at someone who was depressed or someone who was coming back over and over and just not getting well. And a lot of anger actually was directed towards these people because we didn't know how to fix it. And in fact, they were costing us a lot of money as well. And yet they were dying many times, and we just didn't know how to deal with it. So when I talk to my students, I like to compare it with before they discovered that the planets went around the sun. They tried to figure out how to describe that. In this person's world, the planets might be their high blood pressure or their psychiatric manifestations or the use of drugs and alcohol or whatever. And once we realize that for that person, the central issue is that abuse, then we begin to understand, everything revolves around that. And we get a much better model, even if we can't necessarily fix it right away. At least we're acknowledging the reality of what that person's going through. And so I thought, can you teach that? Can you teach medical professionals to actually care about the reality of other people? There are a lot of things that keep us from wanting to do that because we've got the pressures of a job, we've got the pressures of a system that does things a certain way, and if you get too far into the patient's world, you're going to get punished because you need to move on and get that billing stuff in. And so I thought, getting people to another classroom, to another reality, would be a really useful thing for my students. Because in a way I was recreating the house calls that my dad made, but doing it in a way that really was with people as a group that were getting not the care that they needed. And in fact, there were people that, like domestic violence victims, were just being blamed for their own issues, their own suffering, rather than having the integrity to really go and find out what was going on with them. This picture is obviously kind of powerful. It shows the health and the connection for this person, in particular with their situation. The number one cause I heard not too long ago of the loss of housing in our country is the loss of your health in some form. And therefore you don't have employment, you run out of resources, you run out of support systems, and if you happen to have any kind of mental problems that were there, a tendency towards punishing yourself, addictions, trauma, then the folks that have those extra factors often end up on the streets. Very different people, but the end place that people end up is under a bridge, blamed, and kind of modern-day lepers. The other part of this picture that always speaks to me is the guy with his back turned, kind of representing symbolically us. And the pigeons, to me, also kind of say something, because when you start going away from the herd, if you will, in the medical practice, and you start working with, quote, those people, then you have a lot of pushback from the system and from your peers. And very much like saying, why do you feed the pigeons? If you just feed them, they're just going to keep coming, which is really a very superficial way of looking at all those people that are out there. But unfortunately, that's kind of the mentality. And you take on some of the stigma of the people that have already been stigmatized by working with them. And so you have to really make a conscious break with my peer group to actually go and find out what's going on and be humble enough to ask people and to go to them. So I thought those are things that we need to learn in all of healthcare. But I wanted this really dramatic experience of having to do it on someone else's terms, being forced to make it wrap around someone else's reality as a way to improve not just myself, but my peers. So, as I've said before, I kind of went on the street not to save homeless people, but to save myself and maybe my profession, because we were becoming jerks. And we weren't able to deal with the reality of people that were suffering and coming back very sick and costing us lots of money. To me, that's a thought disorder. If you refuse to deal with reality, you've got a thought disorder. And there's reasons why you're trapped like that. And so I went on the streets to hopefully make the connections with people that would accept me in their world and from whom I could learn how they got there, like this little girl's wondering. Most homeless people, this is Dennis Culhane's work, I think, in Philadelphia, but 80% aren't homeless that long in our country. But there's a group of chronic homeless folks that are out there longer that just can't get it together for whatever reason. And they end up being the people that utilize over half the system's resources, and they're people that die disproportionately. So they tend to be the people that are under bridges. And again, that's why that group interested me the most. In our emergency rooms, they frequently use the emergency rooms. This is a study by Jim O'Connell in Boston during that time period, and he had 18,000 people, or visits with 119 people. So they're using the emergency room as their primary care over and over. And the additional cost per person was $22,000. And this is back in the 90s, and it's even higher now. Ironically, he points out the rent here is only $10,000 at that time for the lower end of the housing that they could get. So he famously has a script that he's written, housing on the prescription pad. Different ways of looking at emergency rooms. This may be more for the medical folks here. It's used as primary care. The ERs have a disproportionate number of street dwelling people there. The bottom is from my data at my hospital, Mercy, and I found out that 34% of the people that were in the highest utilizing group in our emergency room, the busiest in the city, were part of our street population. And so the question is, who are these people? And how can we connect with them? To do that, I needed to get into the street population. And this is a picture of me early on with Mike there, who was homeless himself for 7 years. I learned about him by asking and asking, and finally they said, you should go ask that guy. He was going under bridges, giving people sandwiches and trying to get them into services. And when I approached him, I say, I'm a physician. Would you take me along? He said, okay. But they don't really like doctors too much. And I said, I can imagine. He said, I'll take you along on 2 conditions. You don't dress like a doctor, and you don't act like a jerk. He used a stronger word, but yeah. So I got, he laid down Mike's 2 rules. And so I naturally went to the library, and I found a book that showed you how to dress like a homeless person, 52 Ways to Help the Homeless. So here I'm in the backyard, and my 3 little boys come out to see me as I'm putting dirt in my hair. And this looks like fun to them. And I said, well, what are you doing, Daddy? I said, I'm going to visit people that lived under bridges. Why do they do that? I don't know. Can we come along? Well, maybe not this time. So I show up, and Mike says, well, at least you got the look. And so back in '92, he began taking me with him into the places where people were dwelling. And he was trusted. They trusted Mike, and if I was okay with him, then I was okay. And it just opened up a whole new world. I didn't tell my hospital. I didn't tell my malpractice carrier. I thought I probably ought to just pilot this for a while with all my theories and everything, but I just wanted to see, first of all, if I could make connections out there. I like this picture partly because we're trespassing and because the bag doesn't have too much in it, but my ears are obviously prominent. So I'm kind of more of in a not having stuff to give, but more receive in terms of my hearing. And it didn't take long, though, for me to develop a practice. People were bitter about the medical system. They said, I'd rather die than go to the hospital. And I saw people dying. But then when they realized that I was really a doctor, they would break down sobbing, and they would say, one guy said to me, I can't believe someone cares that we're still alive. And he spoke from the heart. And I hadn't heard anything or seen anything like that since I'd worked in India, where leprosy patients, when you gave them a hug, you just feel this trembling of gratitude that you're seeing them as a human being. So it really brought me to tears as well, to be connecting as a human being with people that just had lost all hope. And I knew at that point I couldn't turn my back. And I'd go home at night, and it would be raining. And I used to enjoy listening to it. And now I'm thinking, oh, little Eva, she's 79. She's curled up next to a dumpster, and I know about her, And so I couldn't turn my back. And in fact, one of the homeless volunteers, Danny, had a Philly accent. He said, when he asked about it, the work, he said, it ain't hard going out there. It's hard going home, knowing there's human beings still out there. And so that really spoke, I think, to where we all were as we began to work together. And yet, maybe out of proportion to its integrity, but that stethoscope was a really powerful symbol. And it allowed me to get into people's lives, any other agenda, I think, would have been difficult. And so I began making my own house calls. And pretty soon people would say, I'm okay, Doc, but you ought to see old John. He's down under the 6th Street Bridge. And so pretty soon I developed a practice, a thriving practice, from one bridge to another bridge. And I was off to the races. And I couldn't turn my back on them. I developed a system where I began putting medicines, because you can't just be out there and see what you see and not do something about it. It's not good health care. You want people to get into primary care, but in the time being, there's maggots in this guy's legs, and this person has a blood pressure of 200 over 120, and you got to do something. And so I began putting little Ziploc bags with different medications, and pretty soon I had a backpack, and we were going to town. A nurse started following him around in the hospital, and she said, I know what you're doing. I want to do that too. And I thought, oh, okay, well, here we go. And I said, okay. So we took Carol along, and this isn't Carol, this is Sister Cindy, but the nurses got it. Nurses always get stuff quicker. And I said, we'll take you along. And the men on the street really appreciated it, and the women really, really appreciated having a woman out there with us. And pretty soon we had her paired with her own formerly homeless partner. And so we began working like beat cops. We had different parts of the city where we would know the people really, really well. And I knew I was succeeding when I went to the north side one time, and someone said, "You that doc? Well, if you're with the nurse here, you're okay with me." And so it was kind of, now I was the outsider, and I thought, well, this is really good. There's this really deep bond that's developing with each of our staff. This picture has a lot of stuff in it. First of all, the gentleman there on the bench, we loved him dearly, but he wasn't interested in his own health. He lost all his toes to frostbite. He was coming back to the hospital with bone infections for 6 weeks of IV antibiotics over and over and over. And there's an article, $1 Million Murray, if you want to look that up in the New Yorker, it's online. And that Malcolm Gladwell talked about one guy that was costing all this money. This would be $1 Million Mikey. He was coming back, and we were able to kind of target people like him and pregnant women and high risk. We got those feet to heal up so that they didn't get reinfected. So Sister Cindy's there helping me. She's a nurse. The guy there with the white T-shirt was actually from a church group that was serving food, and I was in the back with my medicines, giving them out, and suddenly he lifts me up when the first time he met me, and he said, "We don't want drug dealers here." And I'm going, "I'm a doctor." And he put me down, and he just was so fascinated. He became a volunteer as well. And the guy with the flashlights was actually still on the street, and he was a volunteer that worked with us. And so, we were beginning to see an investment with each other, and the roles kind of got not as important as just being there for each other. And to me, that was like a deeper thing that was even more important than maybe what I could do myself. So this picture here is another interesting moment that was captured. There's a guy that had a doctor in the past. He needed to get back to him, and I called his doctor. He said, "Yeah, I'll see him. He was a character. I liked him. Where is he?" He said, "He's under the bridge downtown." And, "Oh, okay." And so here I am. He's not there that night, and I'm writing a note. I'm saying, "Bobby, your doctor will see you Thursday at 2 o'clock." And so I've made an appointment, and to me, the bridge in the back is kind of symbolic of, I realized we could connect all these folks out there with the people that needed to work with them. And then if you add on to that a homeless person could call, eventually a toll-free number, and talk to me at 2 in the morning. And I was happy to know what was up with them, because it was going to be a problem later. And so they could call any time of day or night. And then at 3 in the morning or 4, an emergency room doctor could call and say, "We've got a guy, he's got these rings in this ear, and he's got a tattoo of a fish, but he won't give us his name. But we did this stuff to help him." "Oh, that's fish, yeah. He's allergic to penicillin." "Oh, we didn't know that." "Okay, great. So we're going to let him go because we don't have a place. He doesn't have insurance. Can you?" "Sure, we'll see him tomorrow night. We'll get him his medicines. We're working on insurance, and we'll get him to his follow-up appointments." And at that point, I thought, wow, this is almost like having a fire department or something. Like, this should be part of any city that has people that are on the street, because you're like the never sleeping system that's there for them and there for the people that serve them. And so the bridge in the background there is kind of like the bridge symbolically between the street reality world and the rest of the society. Pretty soon people started showing up at the hospital. I needed to tell our CEO, who was a nun and forgave me, and then my malpractice. And they actually offered us a grant we applied for, and we got a grant. We hired Mike officially and another guy and a secretary, and we were a program, Operation Safety Net. And now we come a little further here, and this gentleman knows how to find us, and he trusts us, and he's showing up, and someone's donated him pants, but they didn't give him a belt, so we're very practical. And we're able then to have a place where people can come, and they don't have to be perfect yet. In the clinic where I was teaching, if you showed up 2 hours late and drunk, no one said, yes! They said, that's it. We can't put up with this. For us, if a person's a day late, we say, thank God you're here. We're so proud of you. Have a cup of coffee. Let's work on the next steps. So another Pittsburgher, Mr. Rogers, we love you just the way you are. And that was the continuity of that feeling that you had under a bridge to the next level. So we began trying to take our culture of caring for each other, grace-based, whatever you want to call it, and then translate that into whatever movement people would make to a higher level. And so here's some of our earlier staff members as we got bigger. And we were a thing. And social workers and a full-time nurse, and it was off to the races, 3 formerly homeless guys there. I had a record system, which was odd because, it was like, his name's Bobby, but it's also Michelle, and it's also, something else. And you never know who that's going to be next. So we computerized it back in '92. So we've had electronic records on our street folks since '92. It's gone through evolutions, but this is an old phone. But we can get under the bridge and say, did you know you have a housing appointment? Oh, Doc, thanks. And so it was so much fun creating systems that actually derived from the street world instead of having to be imposed from the top. So that was really cool. So aliases and tattoos go in there and stuff like that. And then we learned that we had to bring the social workers out to the camps to get them their benefits and really make it work. So going to where people are just makes more and more and more sense. It never works when you just say, come, and some people just can't. You have to walk with them with a respect and a trust with each other. So people that are moving through all these different kind of scenarios, now a street team was in the middle. As I did with domestic violence and a consult service I started back in the 80s, because my peers didn't want to know about domestic violence or didn't know what to do with it. That was my big thing early. I created a consult service in the hospital, and that really opened up people's eyes. They were not afraid to admit that it was there, and it really worked. It was a win-win. And we got the nation's first full-time domestic violence advocate in our hospital to do those consults better than I could, and that's when I backed away. But in like model, I created a homeless consult service. And so I think one of the pillars, especially if we're talking about hospitals, of a really good system, there's a lot of parts, but is a street medicine consult service. And it's been shown to reduce length of stay, readmission rates, and several of our offshoot people have funded positions based just on those savings. So it's a really good thing. And I'm sorry, this is kind of geared towards thinking you're all hospital administrators, but the length of stay in a hospital for homeless people is in Stephen Wong's study is like twice as long, and it costs a lot of money. And this is my former student who worked in Boston, Dr. Perry, and he did this program with a consult service and showed that they could get people out a lot faster, and therefore Mass General was willing to fund. The bottom line is, folks in a hospital may be doing their very best, they just don't know where a person's going or how to solve it. And this is the kind of discharge you don't want to see, but we unfortunately still do see occasionally. And we've been able to really address that and prevent tragedies. As I mentioned before, I'm a teacher, so the student part for me is such a great fit. And I know this is a teaching hospital and there's other schools. It just doesn't have to be doctors. It could be nurses, physician assistants, legal, social work. And a lot of the programs, actually, they work wonderfully well together in an interdisciplinary way, which is where we're going to need to go. But on the streets, it's a natural. And so the students are like dear, dear, dear to my heart. They're often smarter than me. They get energized, and they go on to start their own programs and do things. I'm particularly fond of the one in the middle. That's my oldest son. He's now a doctor, one of the ones that saw me dressing like a homeless guy. But it's a great classroom, and it's a unique way to look at health and people. And it's also a really powerful way to look from the outside in and say, wow, this kind of sucks. There's so many things that aren't working, but with people we could do it better in this way and this way. And so it becomes its own, it has legs, and it improves healthcare by seeing it from the point of view of the people that are outside. So I think one of my feelings is that in any community, any health science school in the world that has folks on the street, there should be a classroom of the streets where you can learn how it looks from the outside. It's symbolic of so many other kinds of people that are excluded. It doesn't have to just be street people. But once you begin to think like this, then even if you're an otolaryngologist specializing in, one part of the year, you're going to remember Mary that was under the bridge and how it didn't work. And so you'll think better. So these are some of the health science schools, medical schools mostly, that have started street medicine programs, and I'm really proud of those kids. When I started, we didn't think that we could house people. There are gnomes, yes. I gave this talk to a elementary school, and they go, "It's a gnome." But he's a real sweet guy, but really difficult. And when I started, I thought we could just help these people not die as fast, And then in the late 90s, we began thinking, we can get them some benefits. Let's get them in an apartment because that's all they want. That's all they will accept. So we began putting people in their own apartments. And it was kind of like the early liver transplants. It often didn't work. People try to start a fire in their apartment and stuff. So we learned, like those liver transplant teams, that you need a good team to help it work. And so we got better and better. And then in the early 2000s, Sam Sambaris and Common Ground and those guys in New York piloted the Housing First model. I think Boston was involved. And it became a thing all over the country, and it's revolutionized work with street homeless people. And so we've actually managed to house over 1,300 people that I never would have thought we could have housed in their own apartments. Some people can't make it in their own apartments, and for those we have a whole spectrum now that we've built for housing. But it's so gratifying to make visits now to people that I knew under a bridge, like this guy, that are now reconnected with family and making it and showing up. So the whole story of a person's life can be way more than that, they don't want help snapshot that you get. Unfortunately, though, there are folks like Bill here who, I asked Bill if I could take his picture, and he said, "No, Doc." And I said, "Well, why?" He said, "Because I've been in your office. All the pictures, the people up there, they're dead." And I talked him into taking his picture, because I just had this feeling about him, and he actually did die the next week. And so he and people like Froggy here, who I also took a picture because I knew he was giving up, they began to haunt me. It's like the movie, I began to see dead people. And they were like little Eva, who got kicked to death next to a dumpster. They never figured out who did it. They had him on security, but they never figured it out. And people who froze to death, and they began just haunting me. And I got angry, and I got sad, and I got all kinds of feelings. But I just got to the point where I couldn't not think about the fact that they were just gone. And so the author, Sidney Sheldon, sent me a check for $1,000. He said, "You should be cloned. Here's $1,000." And I thought, this is for me. So what I'm going to do is I'm going to go buy 10 plaques. And I'm going to put "We Remember" on top. And then the name of the person, or nickname, and the year that they died. And I went back a few years. This was 96, back to 92. And I said, "Mike, we're going to drill these in the sidewalk wherever someone died or was murdered. And they're going to accumulate. And people are going to ask what these are. And people are going to care." And so the police politely pointed out we couldn't do this. So we went to the mayor's office, and he said, "Well, heck, we'll give you a wall." So we have a memorial wall. This isn't the big picture of it. It's unfortunately, 150 plaques since I started this. But it's a really, really powerful place because we put the names up, and sometimes if I don't get it up, the homeless guys will write, Frank or whatever. And they'll lay, flowers or maybe a bottle of beer, whatever it is that really meant something to that guy. But it means something. And then one of our nurses got an award, and she used the money to buy that plaque above that just says that, we hope you're doing better up above, and that you're watching down on us. And so there's Homeless Memorial Day National, and that's where we have our memorial service. So we have, now we have these milk cartons that are luminaria. And so we have one for everybody, and then we have the new ones. This year it was 6. And we just talk about what was good about them and funny, and family comes and homeless people come. And we dedicate ourselves to trying to prevent it. It's just for the people that die on the streets, this particular wall. And it's really, when I realized after a while, this is way more, this is like health care. But what it is that we're showing, the first thing is that people matter, and that we miss them, and that we grieve them, and that we're committed, even if we don't know how, to not forgetting them and doing something. And so in a way, it's health care, it's healing, because that's the first thing. You have to care about each other, you know. And I have a lot of angry thoughts about it, but I won't get into those. So that's Operation Safety Net, and that's the program in Pittsburgh. Now, I'll take you briefly for the last part of this back to '93, when I knew that I wasn't going to give up this work, but I didn't know anybody else that was doing it at the time. There were Jim O'Connell and some others, but I didn't know them. And so I felt really out on a limb. And I happened to be in India for other reasons, and some folks told me, you should go up to Calcutta. There's a doctor up there, Dr. Jack Prager, and he's been doing this since '79, and I think you'd find it really interesting. So I made my way up to Calcutta, and on the way I thought, you know, I'm close to Mother Teresa's place. Maybe I should stop by, and I found out who the administrator was, and I came to the door and explained what I did, and they thought it was nice, and I said, can I talk to Sister Shanti? And they said, oh, she's a very busy, you can talk to Mother Teresa if you want. And I said, yeah, that'll do. So she's got to finish her prayers. Yeah, it's okay, let her do that. So we just sat and we talked for like 45 minutes. And so to the young people, or even not so young, sometimes the best rule is just ask, you know, apologize later. There's a bunch of rules. But it was really a really profound experience. But then I went on to meet Jack. And Jack was one of those epiphanies for me, because he was from the same planet. He had been doing this. He saw things the same way. He'd had to grapple with, how do you do the medicines for people that can't read, and you don't want to make sure that they don't take them wrong. What happens when you get chased away by the community because there's too many lepers? And for us, we got chased away because there were too many homeless people. And and how do you be nimble, and how do you work with the community? And your volunteers are weird, our volunteers are weird, and your van's broken, our van's broken. And so it was just, we were doing the same thing, it just didn't have a name. But to see the work in action on the streets of Calcutta, it just really, from that day on, I decided that whatever you're going to call this, I'm going to be dedicated to sharing it, to learning about it, and to helping folks that want to do it, to do it. And so I've been on that mission now since '93. And I learned that there were people interested. Here's Donna in Cleveland on rounds. Dr. O'Hanley in Columbus, they have a program that's not too old, but really strong. And so many programs throughout the United States began to emerge, or I learned about them. But I got better and better teaching this. And then others took up the programs, and here's Andrea doing rounds with her in Prague. So they've got a wonderful street. They've actually translated my manual into Czech, so that's kind of wild to think about. And so, all these people all over the planet began connecting, and every time we met each other, we thought, oh, you get it. And I thought, we really need to bring them together, because they're almost homeless in their own communities. Am I over time? Yeah, all right. Almost there. And so we had the first international meeting in Pittsburgh. And no big plans, just bring them together. And Dr. Prager was our keynote. He's been at every meeting. But it's a unique place where people who do this can get together. It's the only one in the world that I know of where we can talk about, how do you do street medicine? And I gave it a name so it would be a thing. Students come, and they're great students. They have posters. There was 25 posters last year in San Jose. 2 years ago, we were in Dublin. This last year in San Jose, and we're going to Geneva this October. And we've had 6 continents represented. So this is our kind of our network right now. It's still very grassroots, but extremely committed. And I really think it has the potential to help healthcare reinvent itself based on the principles that a lot of our hospital systems started on, doing the right thing like we would want to be treated. And so I think it's adding to a dialogue of a lot of other movements, but I'm really excited about it, and never would have imagined when I put the dirt in my hair it would lead to all this. We have an institute now. The image there was a stick figure that I drew and someone improved it, but it's kind of like if we remember that image, then we'll remember what we do and who we serve and how. And then the tagline there I got from actually a wall in a hospital in Haiti I was visiting. And when I read it, I thought, this is it. Go to the people. It's from a poem, Lao Tzu. Go to the people, live among them, love them, serve them. Start with what they have and build on what they know. And when the work is done, the people will say, we have done this. So that circle there is kind of like you go, you respectfully connect and engage. You get solidarity with people. And then together you solve problems. And I'm sure that community policing is kind of got the same, philosophy is you got to get connected to people. Then they'll respect you and you respect them. And then a lot of the things, not all of them, but a lot of things get possible. And so my homage to the nuns here. And that's our street medicine website. And then Lois, we call her J-Lo, says thanks. So I'm ready for questions, comments, criticisms, whatever you got. Thanks.
Thank you, Dr. Withers. And at this time, we'd like to open it up to questions.
Yeah.
Interdisciplinary care that is that people in hospitals value care that would be able to step in and help the people that you're caring for, either there or in a hospice setting?
Yeah. So, very good question, very poignant question. And we've had to grapple with that. Again, sorry, I always kind of want to broaden first, but the beauty of being part of the fabric of the community of the street is that you just naturally get compelled by those kinds of things. And so the street teaches you kind of what you have to worry about. And one of those things is end of life. Another is severe weather, where we created a severe weather shelter. Another is respite care for people that are really sick, because you see it. When it doesn't work, you see it right under the bridge. So there's this accountability because you're part of the street. And that drives street programs to connect with agencies or create them. And there's a process, I call it InReach, and I won't get into that. But anyway, with end-of-life care, that's a good example of that. We have been able to, at that point, usually you can get them their benefits, their insurance. And I'll do them under a bridge or wherever, and we have teams of kids now with laptops that are enrolling people under bridges. But and so if they're willing to go there, that's to a hospice setting, then we can get that done. And we have a number that have reached out to us to say, we really want to help you guys with this particular population. We now have, in addition to our apartments, we have a building where you need a little bit more supervision, and then an area where we need 24/7 right there supervision. And into that, we've had a number of people have their last days with our staff, but helped by hospice. And so it's a really important, it's so touching to be there for people that got nobody. It's open-ended. It's a permanent supportive housing. It's a safe haven. We need more of those beds, and we're advocating for it. But we just made it happen in the beginning. But we've been able to get the grant people have been able to work out some of that. But we always try to collaborate with others. And that kind of broadens our impact and also, shows that we play well when we're applying for grants. Yep. Yeah. So, there's some things that kind of create the impression with the patients, the clients, whatever you want to call them, that under the bridge is where it's better for them to be medically treated because you're coming to them and they love you and they trust you. They don't trust those people that have burned them before. And some of the staff actually feel they get a little bit of a maybe they love me. Isn't that wonderful? And so you can get stuck in a street perspective. And so we have to collectively remind ourselves and the patient that we're going to be there for you, but we have to work towards something better for you if you want to do this at a better level. And that includes, the prescriptions. But I early on, the only way I could think to do this was to get Ziploc bags and say, here's 2 weeks of your blood pressure pill. It's a safe one. Not enough to lose and cost us a lot of money, but enough that it isn't just stupid. Courses of antibiotics, so those little Ziploc bags point right at the time, to me, is the maximum way to get someone actually treated. Because I tried to write scripts, and rarely would they manage to get there. But some programs like Boston, they have Blackberries, and they type it in, they say, it's waiting for you, it's already paid for. And they get people to do that, but there's a lot of people that they're not even at that point yet. As we get their benefits, then we do gradually move towards higher levels of interacting with pharmacies and primary care and saying, you got to go back to, the health center to get this done. We're always there if things go poorly, but then we always gently apply pressure to get them to a better place. And we pay the co-pays. That's a big barrier from our grants. That's a good important question, and yeah. I mean, if you look at the homeless global thing, 30 to 50% have Axis 1 major mental health diagnoses. That's kind of the general studies. I think that there's some things that are just enormous under the icebergs under the water that we don't really talk about or fully appreciate. One, of course, is childhood trauma, molestations, and beatings, and all that stuff that precede. It's enormous, and it really affects how people look at themselves and what they'll do. Traumatic brain injury, I think we're going to find that some studies are showing 50% or more of the people have had enough trauma to their heads in one form or another that they just don't think straight, and they can do stuff that makes it look like they're okay because they know how to get to the giant eagle and they know how to hustle this guy and they know, but they can't really put it together if you did good testing of them. And then there's the effect of being on the street. It's like domestic violence. After a while, that soul-crushing experience trains you that you're not worth anything, and that you can't really accomplish much. At least that's the impression you get. So you buy into that. And so I like to think of both of those groups in parallel as being in a place where they just can't deal with it all, but they're seeing the world in a really narrow thing. Like, I'll just get through today. I'll just get through this morning. And for them, that's as hard as they can do. And it's by being with them that they begin to say, you mean you're really for real? And you'll be there for me? And then they begin to see other people succeed. And then their menu suddenly gets bigger. And they see options. And they may not believe in them, but as they test you out, and they say, I'm going to give this a shot. And they make more choices. So I think their brains change. Their minds change from that, like, I'm just going to get through today. Like their multiple choice is, I'm going to jump off a bridge or I'm going to have a beer. A beer is like Einstein, if that's the only two choices you got. So over time, people change, and it's a very dynamic thing. But I think the street has its own awful effect on mental health.
That's like I was gonna say, thanks for the ones here, like a living saint right here. It's beautiful to see the dedication and stuff to this. For women and children, I know sometimes they're harder to find because they're trying to stay safe. How would you suggest trying to find those people?
Well, and so many of them are in, women are not the majority of folks on the street. There tend to be probably 70, 80% men. The women that are on the street, there was one study I heard about in England that they have a different path to the street. And usually they're getting away from something that was worse than the street. And men have generally a different way. And a lot of times the kids, they'll put up with stuff or they'll do anything not to have to lose the kids or to be under a bridge. We do see it, but not as often. So there are other groups that find them, wherever they are. We're kind of zone coverage, and if we see them out in a car or in a camp or something like that, then we address that. I try not to strong arm anybody, because anytime you try to involuntarily commit someone or do something, the system tends to not work, and then they end up and they hate you, and they won't even talk to you. When the kids are involved, we just do it, because you have to protect the kids. But you have to kind of sometimes you have to get to know kind of the pimp to be able to work with the girl, because at the time it's like a domestic violence on the street in a way, and so you have to become part of the fabric in a non-threatening way, and then gain influence to help people. But the women that we see, often they've been through awful things, but they often get off the street, like people I never would have thought could have, and they're so courageous to do that. Every person's different. Yes. Yeah. I'm not trained in addictions. I'm not trained in a lot of things, but the streets is just so frustrating for mental health and for addictions, because there's very, very little anywhere that I know of that's quick and easily accessible when someone is ready. And, we'll agonize. We'll know that someone finally is really, really ready because we've worked with them. And then you call and they're put in the back of a long line of people that, they're at all different stages. And we know the person's life depends on quick access. So sometimes if you can go in through a hospital because they're having medical problems, that's one way to get more quickly into recovery services. But in the general thing, they're at the end of the line and they're as dysfunctional as anyone. So it's really, really hard. But we try to make partnerships with programs that are proven and target, just like with any other service. We say, Betty really needs you, and someone will make room. So we try to make those kind of relationships with organizations. I think, this is just my own theory, I think we're doing a form of addiction treatment just by being there with people. If you know the language of change, behavioral change is pre-contemplative and contemplative. Like before you even are thinking about it, you're thinking about it, and then you actually have a plan to change. So those are all these terms that are used. But these are people that are most people would say, well, they haven't hit bottom yet. They're not ready. Rah, rah, rah. And you can't help those kind of people. And so there are all these people out there just dying because they are not ready or they haven't hit bottom yet. And so that's kind of justifying your program, but not the people that don't fit it yet or maybe never will. So I think, again, going back to Mr. Rogers, just by being with people, I've watched this, especially in community. They began to look at things differently. And I get someone, it's at Kmart, it says, hey, Doc, I'm working here. Or there was a guy at the bank. He was the bank guard. And I said, sir? And he said, you saw me under the bridge back in the 90s. And you guys saved my life the night you gave me a blanket. And I've been thinking about it, and I don't even remember him. So there's kind of this, like, you can focus on one person, and sometimes that actually doesn't work as well. And yet when people look at this and they buy into it, then they make the decisions to make the changes. So this is all a little mystical, but this is what I've watched. But when you get a certain barrier, then you can really try to help them. But so I think we're doing something that's related to addictions, but it's not it's outdoors. So.
I'm from the Netherlands,
Oh.
and what I found out basically that they are very, very, very proactive in the Netherlands. You folks know the medical part.
No, I understand. Yeah. Yeah. Yeah, I've done rounds in Amsterdam, and we have a program in Rotterdam, and I just say, well, I wish, the harm reduction and the things that you guys do are incredible. There's a social commitment, though, that we're a bit more Darwinian here about those things. So my experience is that kind of if you build it, they can come, but you have to build something. And so you have to have a component that is an outreach component. It doesn't have to be formerly homeless or whatever, but there needs to be people that kind of keep the beat, that the people on the street know are going to be there, that know them, that don't pressure, but just trust them, just connect. And then into that, you can layer your medical people. And we always try to keep a mix between paid and volunteer. To get some things done, you just have to pay for it. But volunteers are incredible, and you get so much power and energy and skill out of that group. But to do that, you have to have an office, and you have to have someone to coordinate it. You've got to have, I think, a physician champion. That may not be the, quote, champion on the street, but it needs to be someone who'll say, I'll take on the medical malpractice. I'll take on some of this decision making, and I'm willing. Ideally, it'll be a physician that walks the walk as well. And I try to get everybody in our program, even if they're in an office all the time, to do a little bit of street time because it refreshes you and gives you perspective. But you can have a pretty bare bones group and then apply schools and groups. Try not to, unless you're doing like the group kind of place where people come to you, a park or a van, you can have more people. But the teams, I try to keep them down to 4, maybe a little more, a little less, because you don't want to invade camps like a assault team or something like that. Yeah, it's actually really, really, really cheap, and it does an incredibly effective amount of cost savings. It's kind of amazing.
Hi, I work in Seminole County as a social worker working with families with mental health issues, and homelessness is something that we encounter from time to time. And how do you address, as you talked about, even housing, the income barriers to get housing? Because I find with my families that are homeless, they're told that they are too-poor to receive aid for housing because it has to be sustainable. But without that housing, it's been really difficult for them to get the consistent mental health and medical care that they need. And it's, this whole cycle within this hierarchy of needs. And we find that this is really one of the big stumbling blocks to that stability.
Yeah. Well, it's a problem for us too. I fortunately have not just a safety net team of social workers that are, really, really experienced with trying to grapple with that, and they'll find bits and pieces and put them together from different kinds of programs, and they always have to stay up on what's the latest. But actually, I have to give Pittsburgh Mercy, the larger system, credit, because it's a behavioral health system that has a lot of ways of working through that as well. For us, with our folks on the street, it's getting back to his question, you know, there's often a mental health diagnosis. We have to get the psychiatry people to do the work, and that's been a challenge sometimes. But you know, once you get someone clearly not able, you know, they're mentally ill, they have a mental illness, that then brings in some of the benefits. Pittsburgh, we're lucky because housing is still pretty cheap, and some of our partners out in California and places, you know, God bless them, but they're not going to get housing first as easy as we can because we have lots and lots of cheaper apartments. Everything you said is true, and it's difficult. I have people you can talk to, though. Good. Yeah. Absolutely. It might be a little more detailed than I want to totally get into here, but you can email me and we could talk. One of the groups that I think would be hugely helpful is the Tampa Bay Street Medicine Program. It was student initiated, that's what we call it, and they're great. And I was down there earlier this year. So they'd be a kind of a peer-to-peer, but I can give you a lot of like guidance through that because you have to kind of up-manage your faculty for a while. If you want to check out the Rochester Street Medicine Chronicles, one of my favorite students, she came as an art major, sketching homeless people, and she became an AmeriCorps worker, and then she decided to go to medical school, and she started Rochester Street Medicine as a medical student. Now she's a psychiatrist at Yale, developing street psychiatry. But you know, she initiated the Rochester Street Medicine, but it's a 5-part series, and you just see how their university bought into it. Like it was their mission, and they have faculty people bragging about, you know, and I know Emma started it. It's really funny, but you know, clearly she got buy-in, and it's really can be a win-win.
In your mission, and what role faith plays in those who are engaged in what you're doing?
So I'll try to keep it short, but it's a big, wonderful, amazing topic. It's very important to me, and yet, you know, I was kind of raised to show more than tell. But I found that through hard times and my personal times myself, that the work that to me resembles that street doctor back in 2,000 years ago, you know, walking the streets, Jerusalem and other places, that it brings my Christian faith to life, and I understand stuff that I've read like I never did, you know, and it's kind of like God has a sense of humor because it's in doing things that you then it's you that gets it finally, in a way that you didn't before. And so I think as a Christian activity, connecting, whatever, it's really, really, really personally strong. I instinctively chose a faith-based organization to work in. I'm not Catholic, but they have fidelity to mission. And that soil was really profound. And the hospital, the sisters call our program a legacy program. So it reinvigorated their own sense of their start, which was the first mercy in the world. and 7 nuns walked the streets of Pittsburgh in 1847. So they've recaptured that. But then as I've traveled around, I've been fascinated to see how I was a speaker in Nigeria twice for the State Department. And when I was in southern Nigeria, the tribal Christians were listening. They said, this is who we are. This is our faith. This is our tribal values. These are, and then I went up to the northern Nigeria where there were, Muslim, and there were groups that said, this is our Muslim faith. This is who we are, and we need to do this. And everywhere I've gone, and folks that aren't even part of a faith, it connects to something that's sort of primordially important to us, that reinforces their better side. So it's a really interesting thing from the point of view of the people that do. One of the things that I think I have to challenge myself is not to be the savior for other people, or to do this as a thing where I'm such a good guy, but to try to make the dialogue be respectful and engage. And always I tell the students, people are giving you gifts all the time in terms of their wisdom. Listen, acknowledge their strengths. And so for me, kind of a spiritual place is when we really see each other as brothers and sisters. Some of us have had a better luck than others, but we're coming to a table together, and we're really trying to find that unity, and that's a really spiritual place for me that I seek. But it's been a real faith walk, and especially in terms of not just in Pittsburgh, but most of the places I go, the people that start it, the fishes and the loaves just start happening. And you say, what is this? Why are we suddenly getting resources and people, and can we keep up with it? And that's actually more of sometimes an issue than, it'll never work. But you got to step forward in faith to get it started.
And with that, we'd like to...
Oh, great. Thank you all. God bless. Good luck.
I would lastly like to mention that our next Distinguished Lecture Series event will be held not here, but in the Dr. Phillips Center for Performing Arts. It's going to be on September 21st, and we're going to be having Dr. Atul Gawande speaking on palliative care, specifically on his recent book that he has written, Being Mortal. So we look forward to your attendance there, and with that, we'll adjourn.